for having me over the years. So increasingly, we're working in collaboration with our non-surgical colleagues. So Pierre Demecourt and Andrew Streccolini are sports medicine physicians that perform the ultrasound exam and help us in our decision making. These are my disclosures. So from my perspective, hip ultrasound in joint preservation surgery is valuable in obviously characterizing the head-neck junction morphology, but more importantly in looking at the dynamics of the hip, both in impingement and instability condition. And increasingly by combining with diagnostic injections, it will really add specificity to your diagnosis in your decision making. Now, previous studies from the Bagres and Zurich have shown that you can characterize the head-neck junction morphology with good specificity and sensitivity. The group from Lantzen, Germany, have shown that you could actually correlate changes seen on ultrasound with MR measures of cam deformity as well as on X-ray. However, so you could certainly detect morphologic changes, but I think you would agree that the dynamic nature of the ultrasound exam is as an imaging modality is the most valuable. So we've extended the work done in Detroit with Ira Zaltz and Dr. Van Holsbeek, where they have shown that by examining the hip under ultrasound, the range of motion we're actually overestimating range of motion when we do our clinical exam. What we have done is we've learned the ultrasound technique from Detroit, and we're trying to understand how can we use this to understand instability in the hip joint using ultrasound. Now, all of you are familiar with the apprehension clinical test, where you're looking at clinical symptoms of guarding and pain when you extend and externally rotate the hip. Now, you can also do this in under ultrasound guidance by visually and you could actually visually look at the position of the femoral head-neck junction relative to the acetabulum. To be able to do this for a single user with the ultrasound probe, the test is a little bit modified, as you can see. Now, what we have done is this is looking along the femoral neck axis. This is interesting. Okay. So this is looking down the femoral neck, and this is the looking at the acetabular rim. So you draw a horizontal line off the acetabular edge, and then we're actually measuring the amount of position of the femoral head relative to this line. So if you're below the line, it's a negative measure. If you're above the line, it's a positive measure. And then we externally rotate the leg and measure that distance between the acetabular edge line and the femoral head. And it's this difference that we're basically, it's the amount of translation of the femoral head between the two hip positions. And that's the measure that we use to look for instability. Now, this is not a matched cohort study. We simply wanted to look how this measure changes, what the differences are in the normal asymptomatic control population. And we assume that the dancers have hyperlaxity and perhaps more hip translation. So our non-surgical sports medicine group actually takes care of a group of ballet dancers. And as a routine, they have to undergo a physical exam every year. And as part of the exam, they did an ultrasound exam. So this is not a matched cohort study, so therefore the demographics between the two groups are different. However, when we looked at the amount of translation between the two groups, they were actually quite similar. And as a total cohort, there was no difference between the dancers and the normal population. That's just of an interest. Now, based on this study, in general, we use about 2 millimeters or less translation as being a stable hip, and then 2 millimeters and greater as being an unstable hip. And that's sort of what we use in the clinical setting. We did do a matched cohort study comparing between female patients that are about to undergo PAO for hip dysplasia and the control population. Now, in that group, there was more translation seen in the dysplastic group, which is, I think, consistent with our understanding of hip mechanics and hip dysplasia. All right. Now, I know a lot of people worry about the reliability and reproducibility of this test, so we did some intra-rater and inter-rater reliability tests between 3 physicians. Now, I know this is a very busy graph, but so if you're in the green zone, it's good reliability. If you're in the red zone, it's poor reliability or reproducibility. And you can see that with the hip just in a supine position, there's actually poor reliability. However, if you stabilize the hip by flexing the hip, you actually improve your reproducibility of your test. And then finally, when you externally rotate the hip, again, and also by stabilizing the pelvis, you have good you can reproduce the test. And when we also look at the inter-rater reliability, similarly, if you simply measure it in a supine position, it's not reliable. However, when you stabilize the pelvis, you seem to be able to increase your reliability. So this is just to demonstrate that it seems to be a reliable measure that you could use clinically. And then finally, just to illustrate that, especially in the revision setting, there are many radiographic changes that may be the cause of persistent pain. However, by doing exam on the ultrasound, it really adds to your specificity in terms of your source of pain. So this is simply a patient that underwent hip arthroscopy at another center, had persistent pain, and on the scan you could see the quality of the osteoplasty could have been improved. There are sharp edges and rapid, abrupt transition from the head to the neck. And on the ultrasound exam, if you look carefully, you can see soft tissue abruptly transitioning over that head-neck junction transition. And when we do a diagnostic injection into that area, patient got complete relief of symptoms. Now these, I'm going to quickly show you a few cases. This is a 26-year-old female with right hip pain. By classic measures, she's in the mildly dysplastic group. And most of you will just go ahead and do the PAO, but we also did an ultrasound exam as well as measuring femoral version and such. And she did have increased translation, which I think supports the idea of this hip being unstable, and she had a PAO. Now, this patient is more subtle. The classic measures are borderline at best. She had an osteochondroplasty arthroscopically, persistent pain, and you would argue that, I'm sure you could argue that the capsular insufficiency after arthroscopy will make the hip more unstable. And she did have increased translation and, again, underwent a PAO. You could argue you could have just repaired the capsule and augment the capsule and all that, but the important thing is that this supports the idea that she had hip instability after capsulectomy and arthroscopy. And finally, a 28-year-old, again, based on classic measures, borderline. She has increased femoral aneurysm, and again, showing more translation. And in this case, instead of doing a femoral derotation osteotomy, she had a PAO, again, with good results. So these are just to illustrate how ultrasound can be used. So in our assessment, ultrasound should become part of your armamentarium. It is a reliable test to check for hip instability, and hopefully it will add to your diagnostic ability in the future. Thank you very much.